Should I just begin then?
Yes.
Okay. So I'd like to welcome our audience out there. I think we have a couple hundred people. We're thrilled to know that you're out there in cyberspace. And I would especially like to welcome our guest moderator today, Dr. Harold Varmus, who has ventured over from the world of cancer research to mingle with the Alzheimer researchers, patients, and caregivers today. I'd like to thank all of our speakers and acknowledge the collaboration with Rob Edgy of the Alzheimer's Study Group and the Jeffrey Bean Foundation Alzheimer's Initiative, which sponsored today's town hall. So early detection of Alzheimer's disease is the topic of our virtual town hall meeting today, and it's a topic of strategic importance for advancing diagnostics and cures for Alzheimer's disease. And there are many challenges and many stakeholders involved in driving forward this area of research. I guess the question, really the big question, is how do we move forward as quickly as possible? What resources need to be brought to bear? What are the models out there? And our speakers today are eminently qualified to address this topic. And in the interest of time, I won't describe each speaker because there will be, let's see, here's, oops, I'm sorry. Let me back up a moment. So, one more. So here are our speakers today, and the topics that each of them will be addressing. And today we are having 9 slide presentations, which will be given in very rapid order. Each speaker has been instructed to spend 5 minutes, big picture issues in their area. And I'd like to ask people to, the panelists, to hold their questions until the end. Although if they're very brief, straightforward requests for clarification, that's fine, but we're trying to move it along. And the audience is muted for practicality's sake, but anyone may submit a question by typing into the Q&A text box, and we will collect the questions and present as many of them as we have time for during the Q&A session. So without further ado, it is my great, there we go, my great pleasure to introduce Dr. Harold Varmus, who is the president and CEO of the Memorial Sloan-Kettering Cancer Institute, renowned cancer biologist, and former director of the National Institutes of Health. Dr. Varmus is serving on the Alzheimer's Study Group. Okay, and I'd like to turn it over to you. Okay, thank you.
So, Jude, thank you very much for the invitation to moderate this webinar. It's my first webinar, and I'm somewhat handicapped by being on a Mac, but I'll try to make it work anyway. I will be very firm about time limits because we only have a limited period, and I'd like to be sure that there's plenty of time for the audience to chime in and ask questions of the speakers. As June indicated, my primary interest is in cancer, but I was, as director of NIH, intimately involved in developing many of the plans for research on Alzheimer's at the NIH. I'm also a citizen of a country that's concerned about aging and the rapid increase in the number of patients with Alzheimer's disease. And as June mentioned, I'm a member of the Alzheimer's Study Group, about which Rob Eggy will say a word or two in just a moment. Our goal today is to think about ways to make early diagnosis more effective. That means more convenient, more accurate, more reliable, and even reimbursable, and with methods that might include a variety of techniques that range from psychometrics, currently in use, imaging, biochemical markers, and other things. These are incredibly important issues for a variety of reasons I'd like to be a little more explicit about than June was. First of all, it's clear that finding this disease at the earliest possible stage provides the best possible windows for therapeutics. It's often difficult to distinguish between prevention and therapeutics in this domain, but if you can make a very early diagnosis and think about trying to arrest the progression of the disease, it seems to be, at this point, a much more promising avenue for for therapeutic development and trying to reverse the disease, a more challenging enterprise. Secondly, it's likely, depending on the nature of the diagnostic methods, that they will provide insight into mechanism, and they may even provide reliable markers for following response to the therapy and progression. Furthermore, by making diagnosis early, one offers two kinds of tremendous benefit. One is the ability for those who are prepared to entertain the diagnosis, the opportunity to do some personal life planning and to adapt to the diagnosis and to enter into planning for a life that is going to be more limited, planning with a family and planning for the change in life that the Alzheimer's inevitably entails. Furthermore, the early diagnosis provides a cohort for clinical trials, which are going to be increasingly numerous and necessary if we're going to evaluate any therapeutic options that come along. So this is a very substantial list of advantages to making early diagnosis a greater reality. I've learned from my work with the Alzheimer's Study Group that it is already possible to do reasonably accurate, reasonably early diagnosis, certainly long before symptoms are grossly recognizable through psychometric tests. But we need to go beyond that because these are not tests that most physicians like to undertake or feel competent to undertake or for which they're adequately reimbursed. So I'm looking forward to learning more from the experts who've been assembled by June and her colleagues to see whether there are more opportunities for improving the diagnostic accuracy and the time at which diagnosis can be obtained. I'd like now to ask Robert Egg, who's been masterminding the Alzheimer's Study Group, to say a few words, and I say, Rob, no more than a minute or two about what this group is intended to do, may help guide some of the comments that our experts deliver after you're done.
All right, certainly. Thank you very much, and I'll even try and do better than a minute or two. In terms of thinking about the most efficient way for those who aren't familiar with the Alzheimer's Study Group to learn about it, I think the Alzheimer's Research Forum, Alzforum, just produced two very good overviews and recent articles on their website. I also invite you to go to the Alz Study Group website. The main theme that I want to stress is that the effectiveness of the Alzheimer's Study Group depends on conversations just like this one. And we thank many of you for taking time already to advise us and to share what's most important to making you more effective in the work that you are doing. And we stand ready to continue these conversations. Thank you for them. So particularly to June, the Alzforum, and to the Joffrey Green Foundation, thank you very much for setting up the conversation today, and to all the panelists.
Thanks, Rob. Okay, let's see. Oops. Oh, dear. Okay, I'd like to introduce our first speaker, who is Sid Gilman. Sid, if you'd like to step up. And hold on. There's is everyone else seeing the screen? Mine just disappeared. The PowerPoint.
Yeah, we can see it.
You can see it. Okay.
First slide is Sid Gilman.
Okay,
Sid's in the neurology at the University of Michigan, and he's going to talk about some of the things that I've actually just started to outline in very brief detail about the importance and challenges of early detection. Sid, you there?
Sid, are you on the line?
Well, I think we should go to the next person if he's not here.
Okay.
Okay.
All right.
Did you check in earlier? I didn't hear his voice. Let's go to John Morris.
Okay. Good. John?
Yeah, I'm here.
Would you like to...
Can we advance the slides?
Just one second. We'll make that happen in a second.
There we go.
Okay.
Thank you.
Yeah, Nico, I've lost the PowerPoint. So
John's at the Alzheimer's Disease Center at Washington University and an expert in early-stage Alzheimer's.
Right. So thanks very much for the opportunity to participate in this webinar, and I'm very much enthusiastic early stage detection of Alzheimer's disease, and would like to indicate why I think it's important. I would also say that the current criteria that physicians use to make the diagnosis of Alzheimer's disease are in need of updating, because at the time these criteria were developed, there was much less ability and interest in recognizing the earliest stages of the illness. So it may be time now to try to take such entities as mild cognitive impairment, which many people think may be a prodromal form of Alzheimer's disease, and begin to try to understand the etiology of these conditions, that is, what is MCI that is caused by Alzheimer's disease. Now, there are advantages to trying to make the diagnosis earlier. The pros are it helps patients and families understand what the cause of the observed changes are in the mental ability of the patient. And in fact, although it may seem counterintuitive, patients and the families have some reduction in anxiety even in early stage when the diagnosis is given of Alzheimer's disease, because at least now they know what the condition is and can move forward. Another advantage is, as Dr. Varmus indicated earlier, the patient at these very early stages still has sufficient mental and cognitive ability to be involved in planning for his or her future life, residence, where they're going to live, how they're going to live, and things of that sort. And also, as Dr. Varmus indicated, at least presumably, the earlier we initiate therapy, the better the benefit of the therapy, because there's presumably less brain damage at these early stages. Now,
for clarification, because your first bullet suggests that the diagnostic methods that are currently in use for MCI are not necessarily accurate with respect to Alzheimer's. Now, this is somewhat different from what we heard at an Alzheimer's study group meeting, where we were told that the good psychometric testing can make an accurate diagnosis in over 95% of cases, as documented by histopathology. But nevertheless, if you're right and old criteria are being used, then how do we know that early diagnosis, as currently applied, actually does alleviate uncertainty, because we're not necessarily distinguishing between other forms of dementia and Alzheimer's?
Well, I think you can distinguish between other forms of dementing illnesses and Alzheimer's, even in these early stages that are under mild cognitive impairment. And the reference I give at the bottom of the slide goes into that and does document that people, even in early stage Alzheimer's, meet MCI criteria, still get reductions in anxiety and in depressive features once they have at least the etiology disclosed to them. So all I'm saying is we don't need necessarily to continue to use terms that don't have etiologic meaning, such as MCI, which is a level of impairment, but we can begin to assign the causation of those mild impairment, whether it's Alzheimer's or some other disorder. We can do that accurately without necessarily frightening or stressing our patients.
Okay, thank you.
Okay, but there are some potential disadvantages to early diagnosis, and those are listed there. People who are still employed, they may experience job discrimination. They may be eligible for long-term insurance. Some states require cessation of driving once the diagnosis has been given. We've said that the earlier we diagnose, the better the chances for therapeutic benefit, but in fact, our current therapies, even in early stage disease, at best are modest in terms of the benefit. And it was also mentioned earlier that many physicians are not willing or able to diagnose Alzheimer's disease, particularly in early stage, because it takes time. They don't have it. They're not reimbursed for that time. So They also need accurate tools to try to make the diagnosis. So if I can advance the next slide.
Just click on the slide, John.
Okay. We need screening tools for early detection, and these are the features that we would want. We'd want it to be very brief, very easy to use, have good sensitivity, reliability, validity, and we'd want it to capture what we think are the critical features of Alzheimer's dementia, that is, that the individual is declining in his or her cognitive function in relation to previously attained ability, and the decline is significant enough to interfere with that person's ability to carry out custom activities. Now, there are no traditionally accepted, universally accepted screening tools, but a new one that has been developed by my colleague at Washington University, Jim Galvin, and others here, is something called the AD8, which is an 8-item questionnaire that takes only a few minutes to complete and has a positive predictive value in discriminating dementia versus normal aging of about 97%. The only limitation is that it is best administered to an informant, and not every patient at every clinic visit necessarily brings an informant, a family member, with them. When it's available, when a informant is available, this can be potentially a very helpful screening tool.
But John, how good is that in discriminating Alzheimer's from other forms of dementia?
Yeah, don't know that. This is just a dementia screening tool, and then the differential diagnosis would have to take another clinical evaluation. And that then leads to what a current topic is, and we'll hear from Mike Weiner and Ann Fagan and Doug Galasco and others about biomarkers, which potentially, if proven to be valid and reliable, can potentially aid in the differential diagnosis of dementia. There's a great deal of effort in trying to detect Alzheimer's disease, clinical severity of the dementia, by looking at neuroimaging modalities, assaying biological fluids, and studying the protein and genetic signatures of various fluids, including blood. So the potential use of biomarkers, if they are validated, in people who already have dementia, it will improve the ability of physicians to make the diagnosis and differentiate Alzheimer's from other dementias, and it may also be helpful in predicting prognosis. It's possible that a biomarker could also be a surrogate for a therapeutic response of a new agent being developed. And many of us think that Alzheimer's disease is actually a chronic disorder, begins in the brain years before the dementia occurs. So in people who are asymptomatic, do not yet have any clinical sign of Alzheimer's, it's possible that biomarkers could identify those who are at high risk of becoming demented if they continue to live. So this would be an antecedent biomarker. And so this leads to, which is preclinical Alzheimer's disease. As indicated earlier, the process may begin in the brain years or even decades before it causes enough damage to nerve cells that the brain fails and the dementia symptoms appear. So perhaps what we will need is a dual approach. One is to identify, assess, evaluate, and validate biomarkers that will allow us to detect Alzheimer's disease in people without any symptoms, and at the same time develop truly effective therapies that might arrest the AD process in the brain. And this then could lead us to a stage that Dr. Varmus also heralded, where we actually are simply treating people with symptomatic Alzheimer's dementia in hopes of curing them. We all hope that that will happen, but we may want to change the paradigm from curing people with the symptomatic disease to trying to prevent dementia from occurring at all. Thanks.
This is Sid Gilman. I just was able to connect. Can you hear me now?
Yes.
And John, is that the end of your message?
That's the end.
Okay. Why don't we move back to Sid Gilman? Thanks for joining us, Sid. He's the director of the Michigan Alzheimer's Disease Research Center. If we can go back to the appropriate set of slides?
Just one.
My slides should have preceded John,
Yeah,
but
so we
I
need
couldn't connect. But
some central coordinator needs to get back to your first slide.
Right.
Sid, I covered all of your slides. Nothing more for you to say.
Yeah, right, John. So my topic is the strategic importance and challenge of early detection of Alzheimer's disease. Let's go to the next slide, Nico. I thought I would start with a definition, which is that of a progressive neurodegenerative dementing disease. 3 elements: loss of cerebral cortical neurons, neuritic plaques containing beta amyloid, and neurofibrillary tangles. The disease progresses slowly in the early phases, faster in later, and it's often difficult to differentiate from normal aging in the early stages. There's marked neuronal loss by the time of obvious clinical symptoms. By analogy, in Parkinson's disease, 50 to 60% of neurons are lost from the substantia nigra before the Parkinson's symptoms ever appear. We think there may be a similar kind of reserve in Alzheimer's disease as well. Next slide, please. The preclinical symptoms are often attributed to normal aging, sometimes called age-associated memory impairment. So can be, as this progresses, a state called mild cognitive impairment. It is actually well defined on the basis of neuropsychological testing, but there's no common agreement about how to define it. There are those who say it's amnestic, that is, memory disturbances alone. Others would like to have any kind of a cognitive impairment that mildly impairs and becomes symptomatic. Later, there's a progressive dementia, and often the diagnosis can be difficult early on. There are multiple ways in which this can begin, as I implied above under mild cognitive impairment. There can be memory disorders, aphasia, meaning difficulty with understanding or executing language, or a combination of these. Misagnosia, misunderstanding the significance of common objects. Apraxia's inability to perform certain movements despite integrity of the muscles and coordination needed to produce those movements. One way it can begin and can be terribly disruptive to business and social interactions or executive dysfunction, in which there's poor judgment, poor decision-making. As the disease goes on, there's usually a decline in activities of daily living, with misplacing objects that can actually occur very early, losing keys, then difficulty dressing with poor hygiene, wandering, mistaking day and night, wandering outside the house undressed. There are many neuropsychiatric symptoms that may precede the disease or accompany the early phases, often a depression, but also paranoia, suspiciousness leading to paranoia, severe aggressive behavior. Next, please. This graph shows on the vertical scale cognitive decline going down and aging as you go to the right. So the normal effects of aging are some mild impairment in memory. Usually it's with retrieval of proper names. That gets a little bit worse as one gets older, but the names pop back into one's memory, or they can be recalled from a list. A deviation from that leads to mild cognitive impairment, where there's mild impairment of functioning. That has a variable course. In some cases, it just continues on, but does not progress into a dementia. In some cases, often because of a depression or poor sleep or some other factor, the person's cognition can return to what was a previously reasonably normal level for age. But, of course, in many people, that progresses into a progressively severe dementia. Next, please. The importance of early decision, I heard John Morris present. Let me just make a few more points. One can prevent disastrous financial or personal decisions. I happen to have had a patient who ruined his business, or almost brought it to ruin, with poor decisions. He was CEO and founder of a large telecommunications industry in Michigan. One can understand aberrant behavior. Sometimes people behave suspiciously for unclear reasons or become querulous or argumentative. One can also protect a patient from harm by detecting the disease early and make interventions to assist the impaired. Again, substantial neuronal loss occurs even at the earliest stages, so key neuronal connections can still be preserved at that time, but there is neuronal dysfunction. This is the time that we would want to have disease-modifying therapies salvage useful cognitive function. This is what we're aiming to get to with disease-modifying agents that are now used in mild to moderate Alzheimer's disease. That's the end of my presentation. Thank you.
Okay, thank you. Any short questions at this point? Points of clarification for anyone? Let's then move on to Mike Wiener, who's principal investigator of the Alzheimer's Disease Neuroimaging Initiative and at the VA Medical Center in San Francisco. Talk about imaging markers for early detection.
Thanks. It's pronounced, Mike. Thank you. It's pronounced Weiner, as in Weiner, or with one. It's okay. So let's just go to the next slide. I don't know where to click myself. Oh, there we go. So basically, we know we've heard from the previous speakers that Alzheimer's disease is associated with the presence of amyloid protein and tau protein and neurodegeneration. Recently, techniques have been developed to detect amyloid, the protein amyloid, in the brain using PET scans. The earliest studies have been done with carbon-11 TIB, which is a Pittsburgh compound, and that's available only at a limited number of university sites. But now we have F18 amyloid agents being developed by 3 separate companies, and I think that in the future the ability to do PET scanning to detect amyloid is going to be much more widely available in the U.S. and in Europe, and that's going to have a real paradigm-shifting effect on the field because we can detect the presence of this protein. That's not to say that we can detect early Alzheimer's with this, but I'll talk about this more. We know that the Alzheimer's disease begins in the region of the brain called the hippocampus, which is involved in memory, and the entorhinal cortex, which is next to the hippocampus. So on MRI scans, we see prominent atrophy in the hippocampus and the surrounding cortex, and this atrophy can be detected with magnetic resonance imaging. Furthermore, the most prominent reductions of the fluorodeoxyglucose PET signal and blood flow reductions occur in the posterior singular gyrus of the brain. So FDG PET is another widely available PET technique which detects this change. We know that there's widespread neurodegeneration and atrophy in the later stages, and we can measure the atrophy with MRI. But the question for this discussion is what are the most sensitive and specific changes for the early detection of Alzheimer's? And I don't see how to advance this. I don't see a...
Just click on that at the bottom.
On the bottom? Oh, there it is. Okay. It wasn't there a minute ago. So here we have an example. Whoops, let's go back one. I'm sorry. I clicked, and can you just go back one?
Mm-hmm.
So here we have some data from Chet Mathis, who developed the so-called Pittsburgh compound. I'm sorry, it should go back one.
Okay, don't click on the slide then.
Maybe I won't click. So on the left you have a subject who's a normal elderly subject, and you can see that the activity is kind of green and yellow. It's not very hot. On the far right, there's a patient with Alzheimer's disease where you see all these red spots showing the presence of a lot of amyloid because the radioactive agent has bound to the amyloid. And then in the middle, you see 3 subjects who are labeled MCI who have mild cognitive impairment. And this shows you could say the disparity or the variability of the presence of amyloid in patients with MCI. The patient on the MCI on the right shows a amyloid uptake similar to Alzheimer's, and this whereas the patient on the left shows a patient who looks to be more similar to control, and the one in the middle is intermediate between the two. And we still need to have much more data on to what extent the presence of this measuring amyloid in the brain with PET scanning can predict who's going to decline and who's going to convert to clinical Alzheimer's disease. But there is now beginning to be very early data, some of this coming from Dr. Morris's group in St. Louis, that suggests that the amyloid imaging, together with other measures, is going to have some predictive value and be very useful to identify who's got early Alzheimer's disease. Next slide. This next slide shows, this is from Chris Rowe in Australia, and this is an F-18 agent currently called AV1, which is now being tested by Bayer Schering. And this once again shows that a patient with Alzheimer's disease has high uptake, indicating amyloid in the brain. And there are two other compounds, General Electric and Avid, that are also making F-18 PET scanning agents to study amyloid in the brain. Next slide. This slide is an MRI from a normal subject showing the regions of the brain that are affected most by early Alzheimer's neurodegeneration. The hippocampus, which is outlined on the right, and the entorhinal cortex, which is a part of the temporal cortex shown on the left. The hippocampus is an area that we use in the brain to store memories when we first learn things, and this is an area that's attacked early in the Alzheimer's process. And we know from MRI scanning that this area shrinks progressively in Alzheimer's disease, and we think the shrinkage begins in the early stages of Alzheimer's disease. Next slide. This shows some other work showing, for example, on the bottom, you see a region of brain that shows atrophy, which correlates with changes in the object naming, the ability to name objects. So this is a cognitive function that is impaired in Alzheimer's disease, and this shows that this atrophy of this region in subjects who are non-demented predicted progressive impairment of the ability to name objects in about 100 subjects, whereas the top image shows that changes in executive function were predicted by atrophy in a more frontal brain region. So different regions of the brain are associated with different kinds of cognitive functions, and we can predict which subjects are going to have decline in these regions by looking at regions of shrinkage on their MRI scan. Next slide. This is some work that was published in neurology by Jeffrey Kay's group in Oregon. And why don't you just click forward, because this slide has a couple of different lines. Basically, what Dr. Kay and his colleagues did is they looked at the ventricular volume, the amount of fluid that was in the middle of the brain, in a large group of subjects who were progressively getting older, some of whom showed transitions to MCI and Alzheimer's disease. And the point that's made on this slide is that the earliest clinical symptoms seem to be picked up on average at about age 88, as you can see from that yellow, this point here. The earliest clinical symptoms began here, and yet these patients who were destined ultimately to become cognitively impaired began to show atrophy of the brain here, and the rate of brain atrophy was accelerated in this group. So this is evidence that using longitudinal MRI to measure progressive atrophy of the brain, one can identify patients before any signs of clinical cognitive impairment and potentially to predict those who are going to become impaired and demented. Next slide. This is another slide showing that the areas of purple are the regions of brain where glucose metabolism is reduced and compared with normal control. This is done with glucose PET scanning. So this is yet another modality that can identify changes in the brain that predict development of Alzheimer's disease. Next slide. So someday, hopefully not too far off, we'll have a treatment which is shown to slow the progression of Alzheimer's disease. And once we have such a treatment, we will be thinking about prevention trials. We'll be thinking about taking subjects who don't have any impairments, who don't have Alzheimer's disease as far as we know, and trying to prevent the disease at an early stage. And when those trials are done, we're going to try to be doing some kind of risk assessment, especially so we can watch those people who are at the highest risk. And this risk assessment will be done with a combination of tests, including genetic testing, neuropsychological testing, I believe F-18 amyloid imaging, longitudinal structural MRI to detect progressive atrophy, analysis of cerebrospinal fluid, which Dr. Fagan will be talking about in a few minutes. And what we need to do now is additional work to determine the relative value of these different measures and figure out which are the most powerful measures and what's complementary in order to detect Alzheimer's at its earliest stage. And I think that's the last slide.
Mike, could you say a word about the specificity of these various tests for Alzheimer's? Obviously, atrophy and CSF volume may be less specific than amyloid imaging, and do you envision one of these tests being a way of establishing that the disease is Alzheimer's, and others being more effective as means to monitor the efficacy of early intervention?
Yeah, these are very good questions, and there's always the balance, the trade-off of sensitivity and specificity. Those methods which are highly sensitive in general tend to be less specific, although it's possible that the cerebrospinal fluid measurements of A-beta, phosphorylated tau, and other metabolites might have both high sensitivity and specificity. A problem with measuring amyloid in the brain by PET scanning is that you already can see it's highly sensitive. There's a paper from Dr. Morris's group that shows that on the order of 20 or 30% of people in their 70s who seem to be completely normal have amyloid in their brain. And what we don't know is what percentage of those people are going to go on to develop cognitive impairment and dementia, and how long that's going to take. We do know that people who pass away in their 80s and 90s who seem to be cognitively intact have amyloid in their brain. So the presence of amyloid in the brain doesn't mean that you have Alzheimer's or you are going to get dementia. And to some extent, this all will ultimately get into a bit of a definition of how you define what constellation of measurements is predictive, and at what point you define ante-mortem who really has early Alzheimer's disease and who doesn't.
Another way to think about this is dividing them, as you were suggesting, into different classes on the basis of specificity, sensitivity, and perhaps very importantly, a convenience with respect. And once you've established the likelihood of an early diagnosis of AD, having a way to follow the course of the disease, which may not be specific for AD, but is now a useful mode of evaluating the course of the disease and the effects of any potential therapy, might be in a separate category.
Exactly.
Okay, are there any other questions from the larger audience that we would like to address at this point? If not, let's then turn on to the next speaker, Anne Fagan. I don't know if I pronounced that right, from Associate Professor of Neurology at WashU, who's going to talk about fluid biomarkers in the early detection of AD.
Hi, everybody. It's a real pleasure and honor to participate here. It's certainly a timely topic, and I thank you for the invitation. Given our time constraints, I'm just going to jump right in. I'm actually not going to be showing any specific data today, but instead I'm going to comment on some very specific issues in the fluid biomarker field. I'm clicking and it's not going.
Try again, Anne.
Here we go. The proteins, tau and beta 42, are primary components of the neurofibrillary tangles and plaques, which are the hallmarks of AD. So it's no surprise that these proteins have been the most studied as potential AD biomarkers in biological fluids as well. And over the years, studies have consistently found increases in the mean levels of tau and decreases in AD42 in the CSF of people with AD dementia compared to non-demented control individuals. And it's hypothesized that increases in tau is due to the presence of neurofibrillary tangles, whereas decreases in beta 42 in the CSF is due to this protein being sequestered to plaques, with therefore less coming out in the CSF. if you look at a cross-sectional study between groups, there's a lot of overlap values between clinical groups, demented and non-demented. So these measures historically have not met the criteria for being a good diagnostic marker. However, I just showed with the advent of in vivo amyloid imaging with PIB, it's been demonstrated that A-beta 42 in the CSF is actually an excellent marker of amyloid. In particular, people with cortical amyloid or PIB positive have low A-beta 42 values, whereas people without cortical amyloid have high A-beta 42 values. And importantly, we showed that this pattern was observed in people with very early-stage dementia, as well as some people who are cognitively normal. And this pattern fits with the concept of preclinical Alzheimer's disease, which people have talked about here already, which would be AD pathology prior to symptoms. It's really people who are the preclinical folks who contribute in large part to the overlap we see with the AD group in cross-sectional studies. Importantly, we predicted that people, those who are cognitively normal, have AD pathology as indicated by PIB and CSF. They have preclinical AD, we propose, and they will be the ones that will go on to develop dementia. And in fact, we have some preliminary evidence to support this, and I'll be talking more about that at the international meeting up in Chicago. Thus, I think a very important, a really important part of the AD field right now in biomarkers is that A-beta 42 levels in CSF may not only be a good diagnostic marker to confirm a diagnosis in someone who has dementia, but also an antecedent biomarker to identify people with amyloid very early in the disease, even before symptoms appear. The ratios, CSF tau to 42, has been shown by actually 3 or 4 groups now as being highly predictive of clinical progression in those people both with mild cognitive impairment who go on to develop AD, as well as dementia, I should say, as well as in cognitively normal folks who go on to develop cognitive impairment either at the MCI stage or frank dementia. So those are important findings as well. There are also commercially available kits now that allow for rapid and sensitive assays for these analytes in CSF, and now a plasma kit has come out recently as well. Plasma measures of A-beta in the plasma have historically been a dead end, but I think maybe part of that is because the assays that we've currently had in the past haven't been very sensitive, so hopefully these new technologies will help sort that out. There is a promising battery of signaling proteins in plasma that's been recently described, but this, as their utility as potential biomarkers certainly awaits investigation. Nico, you're going to have, okay, there we go. I was also asked to address what some key bottlenecks to progress is, and obviously inadequate funding. But perhaps even more so, it's really what I consider to be a philosophic reluctance, if you will, of federal agencies to fund prospective studies of non-demented cohorts. And as has been brought up earlier, this is really the group likely to benefit most from disease-modifying therapies once they're in the clinic. Another practical problem is that we know that even though CSF so far is the most promising fluid to evaluate, research subjects are very reluctant to undergo lumbar puncture and to volunteer for such studies. There's a tremendous amount of misinformation in both the public and much to our surprise in medical communities regarding the safety of LPs and their importance for CSF analysis and AD research. Also, just in general, there are just too few subjects that have been analyzed. In order for statistics to do their wonderful things that they do, we really need to have hundreds of subjects being followed in such studies. And to date, we really haven't had the resources to be able to do those sorts of numbers. On the scientific side, right now, as John Morris had mentioned earlier, the clinical diagnosis has really been the gold standard in AD research, and specifically in biomarker studies as well. But there are inaccuracies in diagnosis, both for detecting as well as diagnosing individuals early in the disease, especially. And furthermore, by definition, clinical measures cannot be used to identify preclinical cases. Of course, these are people who would have AD pathology in the absence of clinical symptoms. And so unless we somehow sort out those individuals, in traditional biomarker studies, they would be considered the control. But if they have AD pathology in their brain, obviously it's going to cause some problems in interpreting our results. Just from practical and scientific things, there are methodologic variabilities between investigators, and it's really difficult to establish any sort of cutoff value for a biomarker analyst unless we have some sort of consensus onto which assays to use. Also, there's just been inadequate clinical follow-up of individuals after they've been assessed for their biomarkers. We need to follow people a long time over time to see who goes on to develop cognitive changes. And it was really nice to have longitudinal biomarker assessments. That's another thing we don't know, is if markers change over time with the disease. So I think that's one of the areas, too, that needs to be addressed. Now, what changes? The questions I get, and I think there's some clear solutions to many of these bottlenecks. Obviously, there's a real need for public education to increase the awareness of the importance of biomarker research for Alzheimer's disease, and also to dispel the myths surrounding lumbar punctures. I think it would benefit also by if we could increase funding of multi-center efforts, and there are a number of efforts underway. Alzheimer's Disease Neuroimaging Initiative, which Dr. Weiner did not address necessarily specifically, if I recall, but that is a big multi-center trial looking at longitudinal biomarker studies. We have a new initiative, a new startup grant called DIAN, Dominantly Inherited Alzheimer Network, which is following pre-symptomatic mutation carriers and non-carriers over time, and looking at lots of biomarkers in these folks. The party line has been that we can't afford to fund such studies. And I would argue we can't afford not to at this point. So we really, in my opinion, need to have some committed granting mechanisms for the longitudinal study of pre-symptomatic individuals. That really hasn't been a priority at all. In order for biomarkers to have any sort of clinical utility, protocols are standardized also. I'll be the first to admit that every investigator likes their own way of doing things. And I suggest that there be some formal initiatives and incentives for standardization efforts. So hopefully that will come up in the near future. And finally, it would be if there was some inclusion of CSF collection and assessment in some of the ongoing dementia studies. Perhaps as add-on studies to establish studies, if necessary. And perhaps also adding these collections to future clinical trials. That may also speed up the progress.
And this is your moderator. Could I ask you a question about this important issue of identifying pre-symptomatic individuals? What's your attitude toward trying to make use of the individuals who learn that they have ApoE2 genotypes ApoE2 genotypes that are useful for making a risk assessment of Alzheimer's as a way of enriching for a cohort that might be an asymptomatic patients?
Yeah, you bet. And
is the research community confident that these folks represent the garden variety form of Alzheimer's, and that this is as opposed to being a specialized class of patients?
I can't address specifically if there are any neuropathological differences between what the Alzheimer's disease pathology looks like between people, for example, with E2 and E4. I'm not aware of those data. I'm not aware of any differences. I know a number of studies that are ongoing, including one from our group, the Adult Children's Study, in which we're following individuals. We're recruiting them quite young, as age 5. And even though we've enrolled on their family history of the disease, we also have ApoE information on all of these individuals. So as we follow these people over time and look at cross-sectional changes as well as longitudinal changes within individuals, we'll be able to address some of these issues about ApoE genotype. I know a lot of other groups actually enrolled based on ApoE genotype. I know that was a big part of the ADNI stratification strategy as well. So,
is your research community trying to reach out to these new genotyping commercial entities like 23andMe and Navigenetics to try to draw in volunteer patients who are subjecting themselves to APO testing to see if
at least in our studies, maybe John Morris, as the director of the clinical core can address that more directly. But at least in our studies, we take all comers, and we have a really nice assortment of ApoE genotypes in our folks, not just E4 carriers and non-carriers, but specifically 2-3 and 2-4 and 3 and 3-4.
Right. Good. John, do you want to comment?
Yeah, so the way we decided to enrich our participants in the adult children study is not on ApoE genotype, because that can lead to lots of potential difficulties, but rather on family history of dementia, and particularly a family history of a parent who developed Alzheimer's dementia before the age of 80 years. So that seems to confirm at least the same degree of risk of developing Alzheimer's that an ApoE.
Are these patients pre-Sloan mutants?
No, no, that's a separate study that we're doing. That's a dominantly inherited form.
Yeah.
We have that as a separate, really a special group of adult children. But the first group of adult children are simply those who are cognitively normal, middle-aged individuals, age 45 to 74, but enriched for having Alzheimer's by virtue of having a parent who developed Alzheimer's by age 80. So these people, we think, will be more likely to demonstrate the preclinical changes of both imaging and CSF and others in comparison with middle-aged people who don't have a history of Alzheimer's in their family.
In these different classes, the patients who have family history of late dementia, the pre-Sloan mutants, people with ApoE predisposition, do we know enough about the various modalities for testing, especially in imaging, to know whether the readout is different with these different situations?
Well, I think those data are accumulating now in a number of different programs that Ann's slide that's up now indicates, including ADNI. And you heard Mike Weiner talk about a risk assessment profile. I don't think we're there yet, but I think we're getting there. And I wouldn't limit it just to imaging. I think these.
I agree. The question I'm getting at, of course, is whether we're dealing with multiple diseases that lead to the same final phenotype.
Right. I don't think that we have enough information to say that, but at least for what we normally consider Alzheimer's disease, I would say that a paradigm is beginning to emerge that probably this is all, there may be a discussion about this, but the first biologic signature may be reduction of CSF levels of A-beta 42. Then that might be followed by positive amyloid imaging scans. Then that might be followed by hypometabolism on FDG PET scans and structural loss, brain atrophy.
Okay, good. Well, thank you very much. We have quite a few more speakers and not a lot of time. So let's go on to Doug Galasco from the UCSD's Shiley Marcos Alzheimer's Disease Research Center, who's going to talk about translating early detection to the clinic. Doug, are you there? We can't hear you. Doug Galasco?
Let's move on, and then I can reach him.
All right, see if we can work out the audio there.
Yeah,
let's move on to Rochelle Smith-Duty, who's at the Effie Marie Kane, or is in the Effie Marie Kane Chair in Alzheimer's Disease at Baylor College of Medicine, who's going to talk about the role of clinical and research centers of excellence in early diagnosis. Rochelle, you there?
I'm here, and thank you very much.
You sound good. Okay.
I'm really positioned here to extend what were going to be Doug's remarks about translational research a little bit further into translation of some of what we know and what we need to know into clinics and in what kind of environments this can be accomplished. And because I know that you, Dr. Varmus, and you, Rob, are here with us today and interested in these policy issues, I'd also like to raise what I think of as an important set of policy concerns that come up in this endeavor. So I'm clicking to advance my slide without success so far.
Click one more time, Rochelle. Can you see the slide now?
We have
I see the slide. It just doesn't advance.
Okay.
I'm clicking on the arrow. So please advance the slide. Okay, so we all agree about the incredible importance of early detection and early diagnosis, and we don't all have time to tell you the reasons, both in terms of advancing knowledge and helping people, why this is so important. But I want to highlight some things that don't really happen out in clinical practice. So the diagnosis of Alzheimer's disease and all memory disorders, and now our clinics are filled with people who don't have Alzheimer's disease but who might develop it by clinical criteria. So the diagnosis of these disorders is dependent upon the proper investigation and interpretation of symptoms. And we've all started to see people who come into our centers who are already on treatments and don't need to be. So we've entered an era of having to reinterpret in the setting of treatment and even take people off of drugs. So this is going on. Now, biomarkers of disease onset, such as those we've been hearing about, or markers of progression, or markers of therapeutic response, are going to have to be validated against clinical symptoms. The ADNI project is in place to do some, but not all of this. I also think that our research shows biological differences and differences in progression rates between subjects may provide information that's important to management. And this type of information is not typically obtained in clinical settings. So this is just to show you an example of some work that raises the possibility people do not progress at the same rate with Alzheimer's disease. Sid Gilman told you earlier that the conventional wisdom that the disease progresses more slowly in the beginning, speeds up in the middle, and advances at the end. And that's true if what you're looking at is mean group progression. You'll see that type of shape to the curve. But if you look at individuals, even very early on, and this depicts what we found in the early progression rates prior to the first time we saw the patients by an estimated method, you can see that about 46% of them were progressing at an intermediate rate on the mini-mental state of 2 to 4 points per year. About 27% were progressing more rapidly. That's greater than 4 points per year, and about 27% were progressing more slowly. And this is already in the very beginning of the disease. So if people come in already progressing at different rates, perhaps this is something that we have to factor in not only to our treatment and management approaches, but to our design of clinical trials. So this is a...
Can I interrupt and ask you a question about the previous slide is very important, and I'd like to ask you a couple of questions about that.
Sure.
Can you go back one?
Yes.
I think that's a very important point because obviously if these rates vary, that's going to have a big effect on clinical trials. So how reproducible are the rate determinations, and are the rates persistent? If we measure these rates early and late in the stage of disease, do they vary?
You've just asked the question that we asked for the Zenith project we had from the Alzheimer's Association. And in fact, when we use these pre-progression rates in a mixed effects regression analysis to say how predictive is group of observed change over time in a longitudinal study, the answer is it's quite predictive on multiple measures: the ADAS-Cog, the MMSE, the CDR sum of the boxes, basic and complex activities of daily living, and a profound dementia scale that we use in our center. So these are not linear change rates, okay? That has to be kept in mind. But if someone comes in progressing slowly, they will maintain better function on all of these measures over time in a mixed effects analysis. So we think that these are real differences, and we have shown these data so far only very recently in meetings and getting ready to put them out in the literature. So that's one point about progression rates, but there's another point, and this comes from circumstantial evidence from various clinical trials programs, and it suggests that early treatment helps people to retain their abilities better, and that in fact in clinical trials that were double-blind and then had an extension phase where everybody went on medication, those who started off on placebo did not catch up, regardless of which of the currently approved anti-dementia drugs we're looking at. Another finding that comes from our longitudinal studies here is that persistency of treatment is also associated with better outcomes. So I'm going to move to the next slide to illustrate that in the briefest possible way. In a very large study, 641 patients observed for up to 13 years, we created a persistency index. And since we follow 80% of our patients till death, and we know the vital status of every subject who's entered our program, we had survival for everyone and current status up to the time of censoring of this study. We created a persistency index, which is the number of months that you were on any kind of anti-dementia treatment divided by the number of months that you had any kind of symptoms of dementia. And that's, for each of these things, there's an experimental technique for how to determine these numbers. Okay, so once again, this is something you wouldn't do out in your clinic, in your clinical practice, but in a research center it's possible. The median persistency index was 55% of the time between first symptom and death or censoring, patients were on anti-dementia drug. The upper quartile was 70% of the time, and the lower quartile 33%. Does it matter? Well, again, in a mixed effects regression analysis, in this case looking at the ADAS-Cog, but our analysis looked at the CDR sum of the boxes, the MMSE, the profound dementia battery, and activities of daily living. There's a benefit. The group who are in the upper quartile of exposure over time maintain a widening difference from the group in the lowest quartile of exposure on this measure, where a higher score is worse. So you maintain better cognitive function if you're more persistent in your therapy. This is a huge question in the field because our clinical trials, our randomized double-blind placebo-controlled trials, go out to a maximum of a year or two. And so it's the only kind of data we have to look at. So now I'm moving into, well, what are the patient advocacy issues that are suggested by some of these observations? The first one I want to bring up is a grave concern. I think that patients should be able to expect an expert diagnosis, management of their disease, and research approaches in the same location. The ideal management, as I've alluded to, is still not proven or worked out. We don't have a formula to tell everybody just do it this way. But it will likely involve early and persistent treatment that will in many ways be individualized. It may be individualized based upon biomarkers like ApoE genotype. It may be individualized based upon early progression rates or other risk factors. Increasingly, however, the centers of excellence for patient care are disappearing. There used to be, in almost every region of the country, some individual or group practice where everybody said, yeah, if you get a memory problem, that's where you go. These are disappearing completely. In parts of the Midwest, there's nowhere that you can go to receive an investigation specifically for dementia. And Medicare cuts, especially those on the table right now, but any Medicare cuts that impact the reimbursement for care of chronic diseases are going to exacerbate this problem. I live in the third largest city in the United States, that's Houston, over 5 million people. Many of the very best internal medicine groups don't see Medicare patients anymore. And if they do see Medicare patients, they may specifically exclude those with dementia. Now, since research funds cannot be used for patient care, our research centers of excellence are increasingly being separated from our care centers of excellence. And I think that this is a problem because, as I've tried to point out in such a brief set of comments, there are things that we don't know about progression and ideal management that we have to work out in a systematic approach to patients. I think that Anne alluded to the whole issue of longitudinal studies and the reluctance to fund cohorts. In your case, Anne, you mentioned cohorts of normals. But I think that there's a reluctance to support cohorts of minimally affected subjects as well as cohorts of Alzheimer's patients, and there are still things that we have to gain from this. So I would like to see some breakdown in the barriers between Health and Human Services, which funds patient care, and NIH, which funds research, and some kind of cooperation that says in certain circumstances we must develop new standards of care for chronic conditions like Alzheimer's disease, and we have to put an appropriate degree of funding into that. Thank you.
Thank you very much. Now, you mentioned therapeutic strategies that seem to have benefit. Can you say a little bit more about what you do for your patients? I mean, many of us are rather skeptical about therapeutic approaches and Alzheimer's. What are you doing?
Well, first of all, let me say that I'm involved with at least 24 experimental approaches to new treatments, and like everybody else, I'm extremely desirous of having better treatments for Alzheimer's patients. But the treatments that we have do something. And the reason that I think most people don't realize that is that in the research centers, patients are often seen once they're diagnosed and managed by someone else. So there's not an appreciation over time, over the lifespan of the patient for, how treatment has impacted them. That's not true everywhere. Many of my colleagues on the phone and other colleagues I've spoken to say, oh yes, the current treatments do alter the symptomatic course of the disease for years. Okay, I think that that's true. And I find that many patients are undertreated with conventional treatments, approved therapies, simply because no one ever escalates their dose, or they have multiple interruptions. And it was a hypothesis that we had that the interruptions made a difference. And that's why we developed the persistency index and did that analysis. We think that if you start on a treatment, escalate to an appropriate dose, and persist with therapy, sometimes increasing your dose over time, it makes a difference. It doesn't cure the disease. It doesn't stop the disease. But if we can't quantify that right now with the therapies that we have, we're going to see failure after failure in our new studies trying to demonstrate a disease-modifying benefit on the background of current treatments. I think that we haven't planned those studies well enough for the impact, such as it is, of the currently available therapies.
Okay, thank you. Other comments on this topic or others?
This is Ed Gilman. I just want to point out that at the upcoming International Congress on Alzheimer's disease at the end of July, there's going to be one paper on the program that, at least with top-line results, does show what appears to be disease-modifying therapy with immunization. That'll be a very exciting presentation by Ilan and Wyeth. Michael Grunman will be presenting it.
Thank you.
Absolutely.
Okay, let's just terminate this part of the conversation because we have people on the phone. The webinar is going to end at 3:30. Is Doug Velasco audible now?
Hi, can you hear me?
Yes, we can.
I can now. Yes.
Okay, good. So I'm going to cover maybe a fantasy land given some of the obstacles we've heard about, but let's pretend that we do have a number of promising diagnostic methods that are close to being ready. How would we translate early detection methods to the real clinic where patients might be encountering their care? So I'm going to mainly show some concepts rather than data. The first is that there are different stages of detection we might consider. We could try to detect symptoms, and this ranges from dementia, where at present it's not easy, as Dr. Judy mentioned, for a patient with florid dementia to go into their friendly local clinic and get an expert workup. We might also look for accurate detection of early symptomatic Alzheimer's disease and think about entities such as mild cognitive impairment or other terminologies such as cognitive impairment not demented. The other aspect we've heard about is trying to detect Alzheimer pathology, particularly at a preclinical stage at which no clinical evaluation is going to be helpful at all. Here we are either trying to measure a biochemical marker or some other brain index, and in addition to detecting Alzheimer pathology, we may actually detect some other lesions, one of which may relate to vascular factors. So if we are going to talk about bringing detection to the clinic, there are many, many issues to consider. The first is whose clinic? If we talk about simply the Alzheimer's research community and the tertiary care medical centers that many of us work at, That accounts for a minority of patients who have Alzheimer's disease. And so I think we need to think at some point about bringing detection to primary care, where most patients are seen and screening is done. And depending on the detection method, some methods may be more appropriate for primary care, while others may be more appropriate for specialists, such as neurology, psychiatry, or geriatricians. Should we think about out-of-clinic detection methods versus point-of-care methods? And again, issues such as does a patient have to physically come into the office to begin the detection process are important. So, for example, computerized mental state tests could be taken from patients' homes. Brain imaging doesn't require a clinic visit, but interpreting all of these results may well require a meeting with an educated physician. Mental state testing at present does require an in-clinic visit. What sort of toolkit would we need? Clearly different methods are going to be needed depending on whether we're discussing the detection of symptoms or pathology. And then all of this comes with dollars attached. And there are two different kinds of dollars. There are the direct costs of paying for these assessments, but then there are the costs generated by further workup and by treatment and other implications of making the diagnosis. And there also are costs generated by the value potentially of early detection once we have treatments in place. I'll go very briefly through the next slide. This talks about where we are right now, and other speakers have alluded to it. Regarding dementia, at present, we rely on a clinical evaluation with inclusion and exclusion criteria. In expert settings, clinicians are extremely accurate, but in the real world, many clinicians have varying expertise, resources, and time. Biomarkers at present are infrequently used to help to rule in Alzheimer's disease. They are sometimes used to rule out other processes. Regarding MCI, or cognitive impairment without dementia, at present this is a clinical evaluation done by specialty or research clinics. It is not something that is accurately diagnosed by primary care physicians or people lacking expertise. It currently needs psychometric test availability, and it's difficult to prognosticate after making a clinical diagnosis. Currently, the evaluation does not use biomarkers. At present, screening is not a routine, and the paper Dr. Morris listed at the beginning of his talk actually comes down on not screening for dementia, never mind screening for anything else. So let's say that we do think there are some virtues in detection. If we're going to come up with toolkits for early diagnosis, if we're going to look at early diagnosis when symptoms are present, so mild AD or MCI or cognitive impairment without dementia, the routine that would probably be followed is for someone to identify that there are symptoms, either the patient or their family or the physician. This would lead to a diagnostic assessment and the documentation of cognitive impairment and possibly of some very mild functional decline. What can we try and do to make the rubber hit the road and make this available in widespread clinical practice? What's going to need to happen is there needs to be much easier access to psychometric tests, and we need to think about who would administer these psychometric tests. It may not necessarily be the busy clinician. There may be use of functional interviews. Dr. Morris mentioned the 88 as one example, and then access to computerized tests may also be able to help us. Regarding biomarkers, at present, MRI volumetric analysis, as one example, is quite cumbersome, and to make this something that's more readily available, automated volumetric approaches are going to be needed. CSF biomarkers are going to need a great deal more standardization, and ideally we're going to need to have them measurable at local laboratories, not at some central laboratory or at a research laboratory. If we're going to talk about screening for symptoms, then if we talk about things like brief mental state tests, those can sometimes cause as many problems as they solve. If the screening test is not particularly sensitive or specific, it may generate an additional workup, further costs and worries, particularly if there are many false positives. There are missed opportunities if the tests are too insensitive and there are false negatives, and so much research is going to be needed to calibrate these tests. Language and education are formidable challenges to coming up with screening for symptoms across a widespread and diverse community as we see it in the United States. There are many research opportunities looking at brief batteries that could be administered by technicians, for example, informant questionnaires and computerized tests. And I think some of this research process needs to develop in parallel with other methods. And my last slide, in terms of screening for pathology, either rather than symptoms or, in fact, once we've identified symptoms and want to understand what the underlying pathology might be, a blood test is clearly going to be the easiest. At present, we don't have a blood test that diagnoses Alzheimer's disease. We have some promising initial approaches, and I would guess that we would be most likely to come up with a screening blood test that could trigger the remainder of an exam rather than a definitive blood test.
We'll see if very short time at this point. Doug, we're running questions. Can you simply summarize this and let us go on to the next couple of speakers?
Sure. So, in general, then, for screening for pathology, as I say, there are many, many research opportunities, and we need to make some of the existing methods that are showing great promise to be as facile as possible so that they can be tested in real-world situations. We need to integrate diagnostic methods with risk assessment methods and determine the predictive value of screening, and we can only really look at cost-benefit analysis once we have therapies.
Great. Thank you very much. Let's go on to Richard Mose from the Alzheimer's Disease Group at Eli Lilly. Richard, are you there? Richard? I can't hear you. I suspect nobody else can either.
Let's go to Bill.
Bill Bridgewater there?
Yes.
Okay, Bill's a patient advocate who belongs to the National Board of Alzheimer's Association. He's going to talk about the patient and caregiver's perspective on this issue. And if you could try to do that in about 5 minutes, Bill, I appreciate it.
I will be happy to.
Thank you.
My name is Bill Bridgewater. I am a early onset, early stage Alzheimer's patient. Contracted Alzheimer's when I was 48 years old. I have been asked today to address 3 specific questions. Nicole, I'm trying to advance. There we go. First question is, how often are patients with early stage Alzheimer's disease not diagnosed, and why are they not diagnosed? Far too often, individuals with early onset and early stage Alzheimer's disease are misdiagnosed, receive a delayed diagnosis, or are not diagnosed at all. This can occur in our present medical system because many of the signs or symptoms of Alzheimer's are similar to symptoms associated with other medical conditions. Depression, post-traumatic stress, bipolar disorders are examples. The vast majority of family doctors or general practitioners lack a comprehensive understanding of psychiatry or neurology and are unprepared to consider an Alzheimer's diagnosis for patients in their 30s, 40s, and 50s. As a result, their training leads them to consider conditions with similar symptoms. Additionally, employee assistance programs provided by employers today are focused primarily in 3 areas: substance abuse, depression, and domestic violence. As a result, individuals suffering from Alzheimer's do not receive psychological or neurological screening to make an effective diagnosis, and they fall through the crack in the current process. The second question I would like to address today. Nico, could you help me with that?
Yes, absolutely.
Why is the lack of early diagnosis a problem from the patient and caregiver perspective? Individuals develop Alzheimer's disease, however, due to the lack of clear diagnosis, as explained previously, they continue to work. As a result, many of these individuals, through no fault of their own, are placed on work-related performance plans for failure to perform their job duties. Subsequently, many of these individuals lose their employment and seek another job only to lose it in the same manner over time. Other individuals are accurately diagnosed, they are often out of work and have no medical insurance. This places an incredible burden, financial and stress, on the caregiver. Additionally, once a person is diagnosed, he or she is unable to qualify for disability, life, or long-term care insurance. An early diagnosis, followed by treatment, improves the quality of life for both the patient and caregiver. Nico, if you can help me with the next slide.
Yes, absolutely. Here.
And my final question that I will respond to today is, what needs to change? The first thing we need to change is our overall understanding of Alzheimer's disease. It ranks as the 6th leading cause of death in America. One person dies from Alzheimer's every 8 minutes. We should all know the 10 early warning signs of Alzheimer's disease. This information is available on the National Alzheimer's website at www.alz.org. Medical professionals require an improved understanding of early onset and early stage Alzheimer's symptoms. A procedure for screening individuals over 50 should be implemented in conjunction with the annual physical exam process. We must improve to a model where an individual receives an early and accurate diagnosis of Alzheimer's. Through the efforts of research scientists, in the future we will be able to identify individuals at risk in a pre-symptomatic screening process. We must provide earlier treatment alternatives to extend and enhance the quality of life experience for the patient and caregiver. Next slide, Nico. We must develop advocates and drive legislation. NIH funding for Alzheimer's disease research has not been increased by Congress in the last 3 years. The current budget
is for anything else, by the way.
Thank you. The current budget is less than $500 million per year for Alzheimer's research. This has a direct correlation to the amount of research that can be done in search of a cure. We must revamp the existing Social Security system. Navigating the current submission process, the rejections, and appeals is difficult and often takes from 1 to 3 years to complete. Subsequently, there is a 2-year waiting period prior to an approved disability receiving Medicare health insurance. Again, this creates an incredible financial burden to the patient and caregiver. We must amend the Americans with Disabilities Act. Workplace employee assistance programs must be updated to specifically screen for Alzheimer's. In this manner, individuals will have access to their employer's disability insurance and disability retirement programs. And finally, the Genetic Information Non-Discrimination Act, or GINA, must be amended to ensure individuals who choose a genetic screening option are not subsequently discriminated against based on the results of the pre-symptomatic test. A predisposition to Alzheimer's disease is not a diagnosis. Thank you.
Thank you very much. Can we hear from Richard Mose now?
Can you hear me now?
Yes, a little bit better.
Hello, can you hear me?
Yeah, we
okay.
can.
I can. Yes.
Very good. I will just make a couple of comments about the perspective of one person in the pharmaceutical industry about the value of biomarkers. And first I want to go to this next slide here, which will describe what the pharmaceutical industry really has to offer this field. And it's primarily the source of most of the interesting compounds that have therapeutic potential, including a number of ones now that have very specific biologic effects thought to be potentially therapeutically relevant to Alzheimer's disease, including gamma and beta secretase inhibitors and quite a number of antibodies directed toward the amyloid beta protein. The industry also is very good at sorting through these compounds to determine which of them have properties that make them suitable clinical candidates in terms of their bioavailability at relevant tissues, their potential for toxicity, and so forth. And also the industry is the major source of evaluating the manufacturing potential of these compounds. And this is really not trivial, but it's what the industry really can do. If we go then to the next slide, we can see what pharma really needs and the field really needs to exploit or to really evaluate these candidates that are brought forward. With respect to biomarkers, it's terribly important to have biomarkers that really evaluate the pharmacodynamic potency of effects of these compounds. This is particularly true for all of these compounds that are thought to work on some aspect of amyloid production or processing. And in order to interpret the results of clinical trials, it's terribly important to really know with pharmacodynamic measures what
these compounds are actually doing in people in terms of their potential effects on the extent to which they alter the production, clearance, or a degradation of amyloid beta protein, for example. In addition, with respect to compounds that are targeted toward a specific pathology, it's terribly important to have measures that really tell us whether or not a patient with a certain clinical syndrome, namely dementia, actually has the pathology that's being targeted by the therapy. So that's really what the industry and the field need in terms of biomarkers. Also, there's other practical things. Given the large number of clinical candidates that are out there, we need large numbers of well-characterized patients who are volunteers and clinical sites with the expertise to actually conduct these studies, and then, of course, guidance from academics and clinical experts on the design and interpretation of clinical studies. And lastly, if we go to the last slide I have there, we can see what I think were the consequences of not having biomarkers and why the drug development process will be severely limited. I think in the absence of good biochemical biomarkers, we really won't know which hypotheses biologically we have tested when we look at the effects of putative secretase inhibitors and so forth in clinical populations. And that's one of the problems we have in interpreting some of the clinical data that have already been presented. Additionally, I think without good diagnostic biomarkers, the industry will increasingly be stuck with testing compounds with very specific biologic effects in sort of messy clinical populations, essentially replicating current clinical diagnostic criteria. MCI, while it tends to move diagnostic boundaries earlier, has actually received a kind of skeptical reception in the regulatory world because of its heterogeneity. Full-fledged risk studies using just crude risk measures such as age lead to studies that often are not practical to actually conduct. And risk based on biological measures, I think in the long run, are the only really viable way to test the therapeutic value of these new clinical candidates that are thought to have specific biologic effects. So I'll just finish there.
Okay, thank you very much. We have one more scheduled talk by Paul Azen. Is he here?
Yes, I'm here.
Good, thank you. University of California, San Diego, and director of the Alzheimer's Disease Cooperative Study. If you could try to make your remarks as pointed as possible at this stage, and we're already over the time limit, I think. But we will extend, since we got off to a slow start, by a few minutes to hear from you on early detection and drug development.
Great, thank you. I am not able to advance the slides. Okay, great. So I just want to put the comments that have been made on early detection in the context of current progress in AD drug development and talk very briefly about some of the good news and some of the bad news, what we can do better, and one possible vision for the future. So good news is that AD is now treatable. While we need better recognition, the situation is much better than it was 15 years ago. Just heard from Richard Mose, and in general, the pharmaceutical industry is very much engaged in this effort, and we've had productive interactions and collaborations now among groups that don't ordinarily work together, including regulators, industry people, and academics. Next slide. I think that, go back one, please.
Okay, just 1 second.
I think that the basic research in Alzheimer's disease has come up with terrifically promising candidate targets for therapeutic work, including the amyloid targets that we've talked about, but others as well, such as tau and microtubules, mitochondria, and neurotrophins. I think that's very good news. And, I'm sorry, we need to go forward. Okay. But there's some bad news as well. I believe that the drugs on the market only provide modest benefit. I do think they're helpful, as Rochelle Duty said, but the benefits are modest. And perhaps the worst news is that the first 3 major phase 3 programs aimed at developing disease-modifying treatments have all failed. And sometimes
sometimes it seems that we spend more time talking about these failures than promising work that may be more promising. For example, work on Dimebon, that's a potentially symptomatic and disease-modifying agent that has very strong Phase 2 data. That's a program being led by Rochelle Duty. Sid Gilman alluded to the bapineuzumab data from Ilan Wyeth, where there's also encouraging evidence of efficacy of amyloid immunotherapy. There are many, many other anti-amyloid and other disease-modifying programs underway. So I believe that the breadth of trials currently in progress is very encouraging. And next. I'm sorry, back one?
Allow me to move them, so just tell me.
Okay. How does early detection fit in? I believe that, and others have mentioned this, that ultimately early detection is going to mean detection before any symptoms, and then treatment of the neurobiology, which will translate into prevention of Alzheimer's disease. Next. You've heard about the progress. I believe that we're very close to being able to accurately identify people who are going to develop AD before there are any symptoms. Some of the most promising methods you've heard about, including CSF beta 42 that Ann Fagan talked about, amyloid imaging and structural imaging that Mike Weiner talked about, as well as sensitive neuropsych tests and genetic markers. Next. But we need to do better. I think that we need to focus more on cooperation across groups in a pre-competitive environment. I think that we need to find ways to encourage much greater participation in clinical studies, and as you've heard, we certainly need more funding through NIH. But there are some very promising examples of cooperation, and I want to highlight just a few. One is the Alzheimer's Disease Neuroimaging Initiative, which is a cooperative effort on the part of industry and NIH and foundations to develop better biomarkers. The Alzheimer's Association research roundtables bring together regulators and industry and academics. The Society for Experimental Neurotherapeutics is another collaborative group. I think these are the examples that we can build on. And next. And just as my last slide, this is where I think we're headed. I believe that we'll be able to screen individuals in middle life for accurate risk factors for later AD symptoms. That is, we'll be able to identify the neurobiology at an early stage and begin treatment in asymptomatic individuals at high risk. Ultimately, I expect that we will be treating not the symptoms of Alzheimer's disease, but the biomarkers themselves. Just as we treat cholesterol and blood pressure, I believe we will be treating a biomarker such as amyloid, whether it's CSF beta 42 or amyloid imaging. We will be able to treat the biomarker with anti-amyloid and other disease-modifying therapies, and this will take early detection to the point of prevention of Alzheimer's disease. Thanks.
Okay, thank you very much. June, you'll have to tell me. I assume that we're going to wrap this up. Because,
let's see. Well, we have.
How many questions do you have?
There are people. If there are people who need to leave, what I would say is we have many questions, and I can take them offline. We can post them. I can email them to individuals.
Are you going to archive the slides? And can we have a kind of a blog here for this session?
Absolutely.
I would suggest we take perhaps. We're not going to be able to keep people on the line. I myself will have to be off in a couple of moments.
Right.
So if we could
have
just
a few
5 minutes of questions, things you think are particularly important, and I don't see the questions, so you'll have to.
Okay, I will feed you the questions, and then the rest that we don't get to, we will put on the website.
Put them online. Maybe we can have our presenters respond to them online. That would be very useful.
Okay. So I'll pick a number of questions. There were several questions that inquired about serum tests. So there are mentions of CSF, but where's the state of the art for blood tests, which would be more convenient?
I guess that would be me.
And Fagan, I think blood is fluid.
Yeah, I wish there was a blood test. That would certainly help things a lot. So far, as I mentioned, though, blood has been a virtual dead end, and I'm not sure if it's because the methods that we have haven't been sensitive enough to detect certain analytes, and so method development is certainly a priority. But it also might just be the nature of the beast. Cerebral spinal fluid might be expected to be a better place to look for biomarkers because it does bathe the brain directly, whereas by the time brain-derived proteins and other molecules get to the blood, they can be rapidly degraded by proteases that are abundant in the blood, or they can be processed in different ways before they're cleared by the liver. So, again, there are a couple of promising potential biomarker panels. Tony Wiscare's group has come up with a very interesting panel of potential biomarkers. However, those have to be validated and also replicated. So, but there is promise, but right now we don't have anything concrete.
Are there ways to make lumbar puncture less stressful, a little more powerful?
That's an interesting question because we do
fine needles and new approaches.
I think it's just a general miscommunication and misinformation, not only in the lay public, but also in the medical communities and the scientific communities. Lumbar punctures, when they're performed by trained clinicians, are very easy, they're very quick, and they're painless with relatively few side effects. I think public information and education is really going to be what's necessary. And in fact, just anecdotally, we've had participants agree to a spinal tap and then the next week later say they're not going to come back because their physician told them that there was a risk of paralysis. Well, that's just not true. So,
no, that's not true. But how about how much fluid do you normally take when you?
Well, in our research studies, we take up to 30 mils, 30 cc's with no problem at all. That's about 2 tablespoons.
And no post-LP headaches.
We have post-LP headaches in less than 1% of our subjects over the age of 60, and it's probably about 5% in the younger folks. But as participants in research, we say if you have a headache that doesn't go away, come back the next day. We give them a quick blood pass. Within an hour, it's cured. So it's very simple.
Maybe you should put a video of an LP on the Alzforum site.
There are materials. There is a training video that's been made to help ADNI and to help clinical trials. There are published data on methods for lumbar punctures, and a lot of this material is out there and could help clinicians.
Now, is there an opportunity to derive APOE4 and 2 from blood?
You mean the proteins themselves?
Yes.
Sure, yeah. People have been immunoprecipitate and immunoaffinity purify these proteins from blood.
Okay.
I'm not sure what you're asking for, though. Why would
that was specifically what I was asking as a predisposition or a precursor.
Well, the APOE genotype you'd get from actually from DNA, from blood cells, and that is a very, very straightforward and easy thing to get. What isn't known, though, is exactly why the different APOE isoforms lead to either increased or decreased risk. It may have something to do with the proteins themselves. They're only different by a single amino acid. And there's ample investigation now trying to identify, the cellular and biological mechanisms by which it does increase this risk. And there's quite a bit of evidence to suggest that APOE isoforms have effects on A-beta aggregation and clearance from the brain. I think there's also some evidence linking it with tau as well. So there's probably lots of different ways that APOE genotype can influence risk. We don't have a perfect handle on that yet, though.
So I have a question here from some participants. They're, I think, lay people from families that have an Alzheimer history, and a number of people have asked, is the knowledge of our APOE genotype something that would, I suppose, help them understand their risk better? They have not been genotyped, but what's the current thinking on APOE genotyping for risk assessment in this kind of setting?
In the absence of a disease-modifying therapy, it's not a very good idea unless a person is participating in a clinical trial. It's not going to help them know that they have increased risk when we can't do much about it.
The problem is there's increasing attention to genetic screening in a commercial venue, and I think folks from Alzforum need to be in touch with people at 23andMe and Navigenetics to be sure that people are getting good advice. You know, Jim Watson had his genome sequence. He refused to release only a couple of bases, and they're those that relate to his ApoE phenotype.
Right.
Well, comment real quick, if you don't mind. Could I comment real quick too about? And I understand how people are asking about the ApoE genotype, but just in terms of understanding what a risk factor is, you may be. It's like, what do you do with that information if you're told that you have an ApoE4 allele? How does that change your life, and how does that help you? Because many people who don't have an ApoE4 allele get Alzheimer's disease, and many people who have an E4 allele don't get Alzheimer's disease. So it's really not helpful in terms of being able to diagnose. It might help with, once you put it together with biomarkers and other risk factors and whatnot, it might give you a better indication of your risk. But again, it's not a diagnostic tool.
Okay, and then I have questions about. So I think Anne had a comment early on about the reluctance of funding agencies to test non-demented cohorts, and I guess overall the challenges of doing really longitudinal studies in populations that are initially healthy, because you're trying to understand the earliest transitions to disease. This requires a long-term mindset, and particularly if prevention is going to be the goal. So if there are people out there who'd like to comment on how do we get to that, how do we overcome this reluctance, what kind of studies are going to be needed, and also how do we increase public participation? It's going to take large numbers of healthy subjects volunteering. How do you, so a big question, but...
So let me take a stab at one aspect of this, June. And there are many Alzheimer's research centers and cohorts around the U.S. Which are collaborating on standardizing and collecting similar clinical information. There has not been similar standardization across many centers to collect biomarker information or CSF, for example, or imaging on cohorts of normals. ADNI represents one of those sorts of studies. WashU has another. We have collaborative studies with a number of other groups as a third option. But I think overcoming some of the conceptual barriers for people to collaborate is one of the issues, and then building on existing cohorts is one of the opportunities.
June, this is John Morris again, and I appreciate Ann's comment that we need more funding for these longitudinal studies, but I think that there has been recognition by at least the NIA that early detection and preclinical Alzheimer's disease are highly important, and a number of longitudinal studies have been funded by NIA, and I think several have been very long-term. Baltimore Longitudinal Study of Aging, Framingham, Cache County, the Mayo Clinic ADPR study, and more recently they've been very willing to study biomarker studies in non-demented older adults and as we've indicated, in adult children. So maybe Ann's comment really was NIA needs to fund more studies here at Washington University.
This is Rochelle Doody. I just want to mention also that there's a role for the states to get involved, that the state of Texas has funded an Alzheimer's disease research consortium. There are 4 sites currently, and we have both Alzheimer's patients and normal, healthy elderly under follow-up with not only biomarkers and clinical measures, but also DNA, and are doing genome-wide association studies. So I think that states could also contribute to this effort.
Mm-hmm. That's an excellent point, and on a national basis, we have 8 states that have passed legislation to evaluate the emerging onslaught of Alzheimer's in the baby boomer generation and make recommendations to the public, private, and government sectors on what steps need to be taken.
Ladies and gentlemen, I think we're reaching the end of the allotted time. I'd like to thank all of you for your participation. We will post questions on the website along with the slides of the presentations, and look forward to a lively interaction on the website.
Thank you.
Thank you very much for organizing.
Thank you very much, Harold. Thank you, everybody, for participating, and we would very much like to continue this discussion on the website.
Thank you.
So, okay, thanks, everybody.
Bye.